Hi friends, I am Dr. Mayur Kulkarni, your radiology faculty. So let us quickly jump into and discuss some radiology related questions in the recently conducted INI-CET November 2025 exam. So there was a question where they had given a CT head image. This was a bone window CT head image at the level of the posterior cranial fossa, where they had put an arrow and they had asked you to identify what this particular structure is. So is it the internal or the external auditory canal or the vestibular aqueduct or the carotid canal? Let us quickly look at a few anatomic points here. The region which we are looking at over here is this particular roughly a triangular shaped bony structure that I want you to focus on bilaterally. This is what is the petrous temporal bone. So this is the petrous bone or the petrous temporal bone. Now, if we look at the various anatomic aspects of the petrous temporal bone, the apex is pointing medially, and this apex is basically going to articulate with the greater wing of sphenoid. So let us quickly look at certain radiological anatomy aspects of the petrous temporal bone. So it is going to articulate with the greater wing of sphenoid as well as the basi occiput. Now, if you look at this triangle that we have drawn, the base is actually pointing laterally, and the base is going to fuse with the squamous temporal bone, squamous portion of the temporal bone, and with the mastoid air cells as well. Now, if you look here carefully, the anterior surface is going to form the posterior margin of the middle cranial fossa. So this is the middle cranial fossa on both sides. So the anterior surface is going to form the posterior margin of the middle cranial fossa, whereas the posterior surface, as you can see there, is going to form the anterior margin of the posterior cranial fossa. This is the posterior cranial fossa. Yes, and this is where we can see this particular opening, right? And this is called as the internal acoustic canal or the internal acoustic meatus. The inferior surface of the petrous temporal bone forms the external surface of the skull base at that particular site. Now when we focus onto this portion or this opening of the along the petrous temporal bone on the inner aspect towards the posterior cranial fossa, this particular opening or structure, this is what is called as the internal auditory meatus or the internal auditory canal. Now let us look at certain important aspects related to this particular internal auditory meatus. The inner opening towards the posterior cranial fossa, this is called as the porous acoustic internus, where there are certain structures which are going to enter into this canal or the meatus. What are those structures? We are going to look at that in a minute. The canal actually runs for an approximate duration of about approximate length of about 5.5 millimeters to about 10 millimeters. It has a width of average width of about 4 millimeters. The lateralmost end of this canal, right, is sort of a oval disc of bone. It is this particular portion over here, and this has certain orifices or apertures within it. It is like a cribriform kind of an oval disc of bone, and this is what is called as the fundus of the internal auditory meatus. Right, there is a very peculiar structure or a pattern in which various nerves exit through the internal auditory meatus at the fundus, and this is something which is important to note. We are going to discuss that. Now, if you look at the contents of the internal auditory meatus, as certain important cranial nerves that as they emerge from the brainstem, they are going to enter into this particular canal. So there are four important structures which can be termed as the contents within the internal auditory meatus. So the first is the seventh cranial nerve or the facial nerve. Facial nerve, its motor root and its sensory root. right? Both of them travel through this particular meatus. Then another important nerve, eighth cranial nerve, so that is the vestibulocochlear nerve. So we have the cochlear nerve, we have the superior vestibular nerve, and the inferior vestibular nerve. Then we have an artery, which is the labyrinthine artery, which is either a branch of an anterior inferior cerebellar artery or ICA, or arises from the basilar artery. And then we have the vestibular ganglion, right? So these are the important structures or contents that lie within the internal auditory meatus. What is the importance of knowing this is that abnormalities arising from these particular structures can present as focal masses or lesions within the meatus. One such example we are going to discuss is the most common tumor at this particular site that arises from the eighth cranial nerve, and this is a question which has also been asked in one of your exams before. Now I said the lateral most end or the distal end of the internal auditory meatus is basically an oval plate of bone which has certain apertures in it. So if this side is the anterior, this is the posterior, this is the superior and inferior part of the disc, this fundus of the internal auditory meatus is divided into upper and lower halves by this transverse bony crest. Now, how do various nerves and structures exit through this particular fundus? Remember the mnemonic 7 up, coke down. So what is 7 up and coke down? So 7 is the seventh cranial nerve, which is the facial nerve, right? So it is located above, up, or superior to the transverse bony crest. So this is where the seventh cranial nerve exits from the internal auditory meatus into the facial nerve canal. What is coke down? So coke stands for the cochlear nerve, right? So coke down means it is located below the transverse bony crest. So this is where the cochlear nerve exits, goes into the cochlea. Now if you see, this is the anterior part above and below the transverse bony crest. Posteriorly of course you have the superior, right, vestibular nerve, superior vestibular nerve, right, branches which exit above the transverse bony crest, and below it, right, we have the inferior vestibular nerve, branches or radicals which exit below the bony crest. So this is how the arrangement of the various nerves is at the level of the fundus of the internal auditory meatus. Remember the mnemonic, right? It is 7 up and coke down. So that is how you know that the facial nerve exits above and the cochlear nerve exits below the transverse bony crest at the fundus. Now, what is the clinical significance of knowing the anatomy of the internal auditory meatus? It lies in the fact that what are the contents passing through it. And as I said, there are tumors or growths or focal lesions that can arise from these contents. Mainly we have seen that we have the vestibulocochlear nerve and the facial nerve there. So overall, the most common tumor associated with the internal or at the internal auditory meatus, or also the cerebellopontine angle, right? If you see in the posterior cranial fossa, right, you have the cerebellopontine angle just over here, which is almost the same region as the internal auditory meatus. Of course, this is an MRI image, it is seen better on a CT, right? So this most common tumor at this site is the one which arises from the vestibular nerve. So it is called as what? It is the vestibular schwannoma, or also called as the acoustic schwannoma. Now see, what happens is that this vestibular schwannoma, as the name suggests, arises from the vestibular nerve, most commonly from the inferior vestibular nerve. So the patient typically presents with deafness, and see how interestingly it spreads. If you look at this particular area, this is the internal auditory meatus, and this is where the tumor actually begins. Now as it grows, it is going to completely fill up, the internal auditory meatus, but then it will spread along the path of the least resistance. So it will come out of the canal, go into the cerebellopontine angle. So you can see here that there is a big chunk of the tumor sitting right in the cerebellopontine angle. So if you look at this shape, this looks like there is a big chunk of ice cream there, right, over a small tapering cone, which is the extension of the tumor, into the internal auditory meatus. So this is what is called as the ice cream on a cone sign, which is seen in. So this is the ice cream on a cone sign, which is a typical feature of a vestibular schwannoma or an acoustic schwannoma. Got it? Now, another important, clinical point to note here is that now this patient here, we are able to see a acoustic schwannoma with a typical ice cream on a cone sign unilaterally. But when you see such acoustic schwannomas, and you can see on both these post-contrast MRI images, they are enhancing very, intensely. So when you see bilateral acoustic schwannoma, see on both sides, you're able to identify the cone as well as the big chunk of the ice cream in the cerebellopontine angle here as well. So remember that whenever you come across a case of bilateral acoustic schwannomas, then you should always think of a syndrome. And what syndrome it is? It is neurofibromatosis type 2, also called as, yes, what is it also called as? It is also called as Miss-Me syndrome. So what is a Miss-Me syndrome? So Miss-Me syndrome stands for, yes, multiple inherited. So multiple inherited 3 tumors. What are those? Schwannomas, that is what we are seeing here, acoustic schwannoma, meningiomas, and ependymomas. Right, so most common tumor that we see at the level of the internal acoustic meatus and the cerebellopontine angle is an acoustic schwannoma, presents with a typical ice cream on a cone sign, right? But when you see them bilaterally, then this is very typical of a neurofibromatosis type 2 or Miss-Me syndrome, multiple inherited schwannomas, meningiomas, and ependymomas. Yes, so now if we look at this particular structure, right, this structure definitely, yes, we have seen that this is nothing but the internal auditory canal or internal auditory meatus. We have seen the radiological anatomy of this particular structure. We have seen what contents pass through it. We have seen the porus. We have seen the canal dimensions. We have seen the fundus. We have seen the arrangement of the various nerves at the level of the fundus and the clinical significance of identifying a typical ice cream on a cone sign of acoustic schwannoma at this particular site. Yes, so this is the internal auditory meatus. Now another chest x-ray based question was asked, and let us see what the history was. So a 55-year-old man presents with tingling sensations and numbness of the right upper limb. So right upper limb symptoms. And what do you see on chest x-ray? On chest x-ray, ipsilaterally, that is on the right side, you see a mass-like opacity in the apex. Later, he also develops visual disturbances in the right eye. So they have not asked you what the diagnosis is. They want you to make a provisional diagnosis, and they have asked you what is the definitive investigation. So this is like a two-step application based question where they want you to look at the history, they want you to look at the image, make a provisional diagnosis, and then suggest what the next step would be. Let us go about it in a step-by-step manner. So if you look at this chest x-ray, what is the finding on the chest x-ray? Well, the finding on the chest x-ray is that there is a mass-like opacity which is present in the right lung apex. Right, it could be benign, it could be malignant, right? Why? But is there an imaging clue? There is indeed an imaging clue here, very important clue, right? And this is usually seen in most cases of Pancoast tumors as well. What is that clue? If you look at the normal left side, you're able to see the first rib. So you're able to see the first rib, you're able to see the second rib, you're able to see the third rib, fourth rib, very well. But if you try to identify those ribs on the right side, see, this is the clavicle, but you're not able to identify the posterior ends of ribs or the first rib on the right side, which means whenever you see a mass-like opacity and you don't see adjacent bony structures, it means that the mass has invaded into the bone. So this is suggestive of bony invasion or destruction, which then points towards the presence of a malignancy, right? So that is how a malignant tumor is going to behave. So what are the chest x-ray findings that we are able to see here on this chest x-ray? So we are able to see basically that there is a mass at the right lung apex. So right lung apex along with bony destruction, that is destruction of ribs, is what we are able to see. Now, why does this patient have right upper limb tingling and numbness? Is because we already characterized that this mass has features of malignancy. It has invaded into the bone. So this tumor has already also invaded into the brachial plexus nerve roots. So brachial plexus nerve root invasion is what can explain why the patient is having right upper limb tingling, numbness, paresthesias. Why does the patient now suddenly develop eye visual disturbances? Because remember, this is a malignant tumor. It is strategically located in the lung apex, so it can spread into the surrounding structures like the brachial plexus, like the cervical sympathetic ganglia. So what will happen if the tumor invades into the cervical sympathetic ganglion? The patient is going to develop Horner's syndrome. What is Horner's syndrome? Right? Ptosis, anophthalmosis, meiosis, and hydrosis. So of this ptosis, meiosis, anophthalmosis, right, this is going to lead to visual disturbances, and that is how we can explain it. So when you see a combination of a lung tumor, possibly malignant because of bony destruction, invading into the brachial plexus nerve roots, invading into the cervical sympathetic ganglia, what is this tumor? What is this combination called as? This is very typical of a, yes, a Pancoast tumor, also called as a superior sulcus tumor, right? So Pancoast tumor or a superior sulcus tumor, that is what the diagnosis is. Now we have revised this in our revision section. So if you look at lung tumors overall, the first investigation is usually chest x-rays. For lung tumors, the overall best investigation usually, remember, is a contrast enhanced CT for imaging, right? However, there is one exception to this, and that exception is a Pancoast tumor, for which the overall imaging investigation of choice is contrast enhanced MRI. Why? Because what is the clincher of a Pancoast tumor? It is neural invasion into the brachial plexus nerve roots, into the cervical sympathetic ganglia, and MRI is a much superior imaging modality which will show you this neural invasion much better. So if they ask you specifically for Pancoast tumor, the best imaging investigation, then remember it is a contrast enhanced MRI. So look at the clincher of Pancoast tumor here. Elderly male, chronic smoker, presence with cough and hemoptysis. In this patient, there is a left-sided apical mass. In the exam, there was a right-sided apical mass which was asked. Because in this image, there is a left-sided apical mass. The patient presents with left-sided Horner syndrome, left upper limb pain, paresthesia, weakness because of the invasion that we discussed. This is typically Pancoast tumor. The same findings in your exam were on the right side. Another typical lung tumor related spotter that I want you to know is this big chunks of metastatic deposits within the lungs. So these are a result of aggressive primary tumor which has extensively metastasized to the lungs. This is called cannonball lung metastasis, seen in aggressive primaries such as renal cell cancer, scrotal mass. The most common primary tumor associated with a cannonball lung metastasis is usually a renal cell cancer. Now, we are discussing Pancoast tumor, so let us quickly look at certain specifics related to Pancoast tumor. Look at this chest X-ray image. We have already characterized it. A mass-like lesion with bony destruction is a malignancy in the lung apex. You can see on the CT, the mass-like lesion is invading into the ribs, destroying them, spreading beyond the rib cage as well. Now, let us look at certain specifics related to Pancoast tumor. What is the overall imaging investigation of choice of Pancoast tumor? It is ideally, we have discussed, it is a contrast enhanced MRI because an MRI will show us the neural invasion better. If they ask you overall investigation of choice, then it is the investigation which is going to give you a histopathological diagnosis. So it is going to be a biopsy. How will you do that biopsy? It is very difficult to reach the tumor, through the bronchi. So a bronchoscopic biopsy is usually not feasible. So it is usually a transthoracic biopsy. But remember, when you do this biopsy, you have to do it under some kind of imaging. So it is usually a CT guided transthoracic biopsy, which is the most definitive investigation which will give you a histopathological diagnosis. Speaking of histopathological diagnosis, what is the most common histologic subtype which is associated with a Pancoast tumor? These are usually, remember, non-small cell tumors. So these are usually non-small cell tumors. Most commonly, these are squamous cell tumors, right? Followed by adenocarcinomas, right? So most commonly squamous cell tumors, but overall they are non-small cell tumors. Remember, overall staging and prognosis wise, it is not good. They are usually at least stage 3. When they are detected, the overall prognosis is not good. A 5-year survival rate is usually about 30%. 5-year survival rate is usually about 30%. And for some reason, right-sided Pancoast tumors have a worse prognosis than left-sided tumors, right? So certain specifics related to Pancoast tumor, maybe the next time they ask you about Pancoast tumor, but they ask you one of these specifics, maybe which of the following is are true except which of the following is false, and that is the reason why we have had this in-depth discussion here. So if you look at this chest x-ray, there is a right apical mass with bony destruction. It is malignant. It has spread into the brachial plexus nerve roots. It has spread into the cervical. It has spread into the cervical sympathetic ganglia. So we have already seen it, a mass on this particular image. The definitive investigation to set up to obtain a histopathological diagnosis, nerve conduction velocity, no, it will not give you a definitive diagnosis. Sputum for microscopy won't be able to give you a definitive diagnosis. USG won't help in this case. So among the available options, yes, it is a CT guided biopsy. We have already discussed. For a histopathological diagnosis, you have to do a CT guided transthoracic biopsy. If next time they ask you the overall imaging investigation of choice for this condition, then we have discussed it is going to be a contrast enhanced MRI. Yes. So friends, remember, be it about radiology or be it about your life, the clarity of thought comes when you think deep. So deep thinking is what is going to give you more clarity, right? Remember, the key to crack your exams is to see as many images as possible as far as radiology is concerned. When you see each image, it pushes you to think more. And when you see such images, you try to interpret them, you think about those findings, right? And you read about those topics as we have done today here, right? You end up revising more and more topics, and that is what gets you to a better position. So the purpose of this recall is not just to do a recall of the questions, but we have revised these topics. We have went into deep thinking. We have studied what is the internal acoustic meatus, its radiological anatomy, its relations, its contents, its clinical significance. We have studied the Pancoast tumor, how it is a very typical clinical clincher. We have discussed a few specifics about it. By doing all this, we are reinforcing all these circuits in your brain, so that you go into your next exam, you see a question related to these topics, and that particular circuit gets activated. And that is how we are going to rock the upcoming exams. All the very best.